So those are the 4 components of approach. Now we're going to go through the next step, which is now you're in the clinical encounter and you're talking to someone and you want to assess, is it relevant to talk to this person about firearms? Now, there may be plenty of people out there, depending on what kind of practice a clinician's in, that for whom it's not relevant to have a conversation about whether or not there are firearms in the home. But there are some situations, many situations, where risk is present. And if somebody has those risk factors, it may be relevant for the safety and health of themselves and or their household to assess their access to guns and their willingness to collaborate on coming up with a solution to reduce the risk of harm. So the first component of assess is to assess for risk factors, and we'll talk about what some of those individual risk factors are. Children and teens in the home are a general risk factor for lots of things, but generally for firearm related injury as well, because especially with younger children, they can access firearms and often do without parents' knowledge. There are also demographic risk factors for suicide and for violence, both being victimized by it and perpetrating it. But those demographic risk factors are so broad that they're not necessarily useful in a clinical setting. So we're going to talk about the more individual ones. As far as youth and firearms, most firearm suicides among adolescents and also mass shootings, particularly school shootings by teens, are done with a family member's gun. So a gun that they had access to within the household. And as I mentioned, they often have more access than parents and caregivers think. There's some alarming surveys that the parents and caregivers say, oh no, my kid has no idea where the gun is and would never touch it. And when they survey the kids say, oh yeah, I handle the gun. And about a third of firearm owners living with children and teens store all of their guns in the safest way. So what this means is that 2/3 of firearm owners have at least one firearm that is not stored in the safest way with kids in the home. Heavy alcohol use or problematic alcohol use also is associated with both suicide and violence. So one study found that a third of people who died by suicide had alcohol in their systems, but those who used a firearm were more likely to be intoxicated at death compared to those who used less lethal methods. So it seems that there's an association between alcohol and more violent and more lethal methods of suicide. There's also an association between alcohol and violence, and alcohol-related criminal convictions are a strong predictor of future violence, even if the original conviction didn't involve violence. So problematic alcohol use in the home is another risk factor to assess for, as is dementia. One small study in the South found that 35 to 60% of people with dementia live in homes with firearms. And when they have access to firearms, they can put themselves, their family members, and their caregivers at risk. So there is an increased risk of suicide in the early stages of dementia. And then depending on how things progress, people with dementia become confused and sometimes paranoid, and that can put others in the home at risk of being victimized by them. And a firearm in that mix can obviously make things more lethal. One way to approach this is to treat guns like car keys. This is something that maybe the access over time as the disease progresses may have to change. And the last risk factor that we'll talk about assessing for is the presence of intimate partner or domestic violence within the home. About half of female homicide decedents are from incidents of intimate partner violence. And when an abusive partner has access to a gun, the risk of death in that interaction goes up about 5 times. But firearms are not just used to kill people in domestic violence incidents. They're also frequently used to coerce and threaten and terrorize people and leave lasting psychological scars. Domestic violence is also related, as we've seen, to mass shootings, and it's often a precipitating incident for mass shootings. So if you have the sense that somebody who's one of your patients or clients is in a household where there's intimate partner or domestic violence, that again is one of the situations where you want to screen for access to firearms. Even outside of having individualized risk factors, another thing to assess for is ideation or threats. So even if somebody, has nothing we talked about before, but they're saying things like, I want to go into my workplace and kill my boss, or I'm having thoughts about ending my life. If somebody makes those kinds of statements or threats, they should always be taken seriously, and they should always be asked about their access to guns. These statements may come to you directly, but you may hear about them from other parties, such as concerned parents or family members or even employers. If these risk factors or the ideation or threats are present, then the next thing you want to assess for is whether or not this person has access to any firearms. And it's important to normalize this topic and really keep the focus again, not on anything political or your own personal feelings about having guns in the home, but really keep the focus on risk and safety for the patient or people within the household. Here's an example of one way you can broach these conversations. This pediatrician is saying, I ask all caregivers about things that pose a risk to their families: water heaters, pools, medications, firearms. What steps do you take to reduce access for those who shouldn't have it? And then the last thing to assess for, if you find out that somebody does have risk factors, even if it's just children or teens in the home, and they do have access to firearms, is whether or not they're able or willing to collaborate with you to help choose an intervention or an action that will reduce the risk of firearms in the home. It's always preferable to have a collaborative relationship with the person and work together, maybe even with their family members or their caregivers or the rest of their support system, to work together on solutions, although there may be situations where that's not possible, and we'll talk about those in a minute. So those are the 4 components of, oops, hold on. There we go. Oh, and here's a way you can use some language to assess people's level of collaboration. This is me talking to a patient who I deemed was at risk of suicide. And I said, lots of patients I see have guns at home. Sometimes when someone's going through a hard time, they store their guns away from home, like with a friend or at the gun range or gun store. This is just temporary until they're feeling better. Is this something you'd be willing to consider? So kind of approaching the idea and seeing what they think about working with you to do something collaborative and voluntary. And I use language here like temporary, just to make sure that they're aware that this is something that, they're conceding to and it's only short-lived.